Brigadier retired Dr. Jamal Ahmed. He is Professor of Pulmonology and Head of Pulmonology at Fauji Foundation Hospital and Foundation University Medical College, Rawalpindi.
إياك نعبد وإياك نستعين. Corticosteroids in the management of asthma. In airway diseases. Airway diseases include bronchial asthma and chronic obstructive lung disease. This is the hospital where I am working as consultant pulmonologist. Before going into the talk, I will briefly tell you about the myths and which are being in the mind of doctors and patients about management of asthma. People usually believe that these inhalers cause addiction. They can stunt growth of children. Inhalers are harmful for steroids are especially harmful for patients, and they are the last resort. So they do not rely on using these inhalers for management of asthma. But the fact is that they are not habit forming. They do not prevent growth of children. They deliver very small amount of steroids which are not harmful at all if they are used in proper dose and for proper time. Airway diseases have been discussed before, and what I want to highlight is that there is chronic inflammation in the airways which cause obstruction of the lumen of the airways, which leads to airway obstruction and symptoms of bronchial asthma. And in chronic obstructive lung disease, which is the third leading cause of death, there are environmental factors like smoke and smoking and environmental smoke, which over time leads to obstruction, chronic inflammation and damage to the lung parenchyma. And there is chronic inflammation in these airways, and which leads to structural changes. So to control this inflammation, we need inhaled corticosteroids, which inhibit inflammatory cytokines and leukotrienes, which inhibit the activity of mast cells and eosinophils, decrease swelling and mucus production in the airways, and leads to improvement in the airways. These are different types of inhaled corticosteroids which are used in low, medium or high dose. And as has already been discussed in GINA guidelines, inhaled corticosteroids are being used in first in step 1 to step 5 in different doses. In step 1 and 2 in low dose, and in step 5 definitely in high dose to control the symptoms of asthma. And in chronic obstructive lung disease, we use inhaled corticosteroids. Inhaled corticosteroids are added in management of chronic obstructive lung disease when the patient has severe disease and their eosinophil counts are more than 300. And those patients who need hospitalization, this has already been discussed. So as we have discussed, inhaled corticosteroids reduce inflammation, and other anticholinergics which are used as inhalers, they just relax smooth muscles. Even beta-2 agonists, they also relax smooth muscles. They do not significantly control inflammation, which is the main cause of problem in these patients. So in different studies, it has been shown that inhaled corticosteroids are effective in achieving disease control and reduce the frequency of exacerbation. Then there are certain side effects of inhaled corticosteroids also, which should be kept in mind. The most common side effect is oropharyngeal candidiasis, which may be associated with hoarseness of voice and cough. And this is due to the local immunosuppressive effect of these inhaled corticosteroids, which cause overgrowth of candida. This is a very common side effect and can be prevented by by maintaining oral hygiene practices, rinsing the mouth after using of inhaled corticosteroids, and using spacer device also reduce this oropharyngeal candidiasis. Other systemic side effects are much less common as compared if we use oral corticosteroids. These include osteoporosis, cataract, drug-induced Cushing's. An important side effect of inhaled corticosteroids in COPD is increased risk of pneumonia. And it is said that low basal eosinophilic count is associated with significantly increased risk of pneumonia. And it is said that up to 69% of increased risk of pneumonia is observed in cases of COPD who are given oral corticosteroids, inhaled corticosteroids. And but this risk is also depends upon the dose of inhaled corticosteroids. If it is used in low dose, then the risk is less. If it is used in high dose, the risk is more. There are few studies which have shown that there is increased risk of tuberculosis in patients with COPD who have previous tuberculosis, who have latent tuberculosis, but the beneficial effect of these inhaled corticosteroids outweigh the risk of tuberculosis. There are studies which have shown increased risk of non-tuberculous mycobacterial infection in cases of chronic obstructive lung disease who are given high doses of inhaled corticosteroids. And fluticasone, which is used in inhaled corticosteroids, is associated with higher risk of tuberculosis than budesonide and beclomethasone. We will discuss it in a few minutes. Osteoporosis is, these effects are much less common in inhaled corticosteroids as compared to the oral drugs. So if we compare inhaled corticosteroids with oral corticosteroids, the side effects are much less as compared to oral corticosteroids. And if the patients are not managed with inhaled corticosteroids, then we have to use oral corticosteroids, which can increase the risk of these problems like elevated blood sugar, high blood pressure, weight gain, hormonal problems, osteoporosis. And if we compare oral corticosteroids with inhaled, their doses are much less as compared to the oral corticosteroids. So their side effect profile is much less. And if we compare different inhaled corticosteroids, fluticasone is a potent inhaled corticosteroid, but it has high affinity for glucocorticoid receptors, and risk of oral thrush, systemic side effects is much more common as compared to budesonide, which has high first-class hepatic metabolism, and it has reduced systemic bioavailability and systemic side effects. Similarly, beclomethasone has moderately potent inhaled corticosteroid, and its side effect profile is much less as compared to fluticasone. Cisletonide is a newer generation inhaled corticosteroid. It is not available in Pakistan, but it has minimal systemic exposure and less side effects. Similarly, mometasone is also has low systemic bioavailability and better safety profile. Now, different types of inhalers are being used in Pakistan. Meter dose inhalers, they can irritate the throat and cause hoarseness of voice, but if we use them with spacer device and we tell the patients to rinse their mouth after use of inhaler, these side effects are reduced to minimal. Dry powder inhalers are sometimes better in those patients who cannot use use meter dose inhalers. These are available in different forms, in capsules and in devices like this Nexthaler and Seretide discussed. Nebulizers are used in elderly patients and in young children, and in those who have severe respiratory compromise. But there is risk of infection. Overuse can lead to systemic side effects, and the maintenance and cleanliness of these inhaler devices are required to prevent these side effects. Then different types of different size of particles are being used in inhaled corticosteroids. Larger particles are deposited in the upper airways, and they do not reach the small airways to improve the symptoms. And this extra fine particles, silicyanide and beclomethasone, if they can reach the later part of the airways, and they can improve the symptoms in a better way. But their systemic absorption may be increased as compared to the larger particles. But even then, they are more effective than large particle inhalers. Some say that in pregnancy, inhalers are should not be used, but they have reduce the risk of side effects, and controlling their symptoms is very important. These inhaled corticosteroids are immunosuppressive in high doses and anti-inflammatory in low doses. So we use them, we try to reduce the dose once their symptoms are controlled. And we use lowest possible dose when the patient improves and reduce. In bronchial asthma, we use step-down treatment to maintain their symptoms and gradually reduce to lowest possible dose of inhaled corticosteroids. In the end, I would like to highlight the fact that as in bronchial asthma and COPD especially, treatment does not complete by just writing the prescription. Patients' education, their inhaler techniques should be checked and verified and on every visit, and they should be taught about the side effects of the use and safety of inhalers before giving them the prescription, so that they confidently use these drugs and their symptoms also improve. So in the end, I would like to say that asthma is an inflammatory disease, as we have mentioned. Inhaled corticosteroids are main drugs to control and prevent exacerbations. Inhaled corticosteroids in COPD, these are used in only selected cases with raised eosinophil counts, and proper inhaler is of particular importance, and patient counseling about safety of inhaler use is very important, and regular follow-up for proper dose and dose reduction is the key factor in managing these patients. Thank you.